So this is a young man with high pressures and signs of glaucomatous optic neuropathy. Given his age of 20, this is obviously some form of juvenile glaucoma. When we were examining the angle, I was pointing out the landmarks, which were a low iris insertion with small iris processes, and it was difficult to see the ciliary body band. But we could identify the scleral spur and the ciliary body band a little bit towards the superior side. So he has actually got a somewhat immature looking angle. So this might be a late presentation of primary congenital glaucoma. And so doing an angle procedure as we would for primary congenital glaucoma may well be a way to control his pressure, at least for the first few years. So you can see the iris. And the iris is going into the angle in a very horizontal plane. There's no angle recess that we typically see in adult patients. And where it is entering the angle is pretty much at the level of the scleral spur. You can just see little glimpses of a bright white line. It's more apparent here. So you can see a little bit of ciliary body band. And then above that is the white scleral spur. And the last little piece I was doing there was blunting the proline suture that we're going to thread into Schlemm's canal. And we make that little mushroom with the cautery so that it's not a sharp tip, otherwise that would tear. And the idea is that we're going to try and introduce it into Schlemm's canal and try to feed it the whole way around 360. And we put a little mark on that proline suture, because when one's feeding it in, one doesn't always know where one is. And if the mark passes you, you know you've gone beyond what you anticipated the Schlemm canal diameter to be, and maybe your proline suture has gone somewhere else where it shouldn't have. The idea is to try and create this incision along the trajectory that you would want the proline to be feeding in. In other words, it's going to be directed towards the angle exactly in the plane you want it to feed in, so that there's no vector pushing it too high or too low. And one keeps it quite small because that's just the suture that one's going to be putting in there. I'll have a little bit of Helon. So I'm positioning the foroproline more or less where I'm going to need it. So it's in the eye. And we've just got to be very careful that we don't inadvertently pull it out, because that happens very easily if it touches us. I'm now going to take the gonio lens and the 23 gauge needle. And I'm going to make a tiny little goniotomy slit in the angle, which is going to provide the starting point for this. And once I've made that little slit in the TM, I then just put a little bit of Helon in to open up the lips of that. And as I say, that makes the landing strip even more easy to identify. So I'm just blowing a little bit of Helon GV in there. Now it's interesting that the angle, Schlemm's canal, seems to be a long way posterior to where these are attached. And that almost looks like ciliary body band down there. So I may have made this a little low, but we'll see how it threads. So now I'm trying to thread it into Schlemm's canal. And what's reassuring is that I can see the blue in the right anatomical position that matches Schlemm's. You know, that looked perfect there. That all looks like angle there. But here, it's just difficult to see quite where it is. So I think as a precaution, I'm going to pull it out carefully and go from the other direction. Now the eye is still turned, unlike when we did the para the first time, so I have to compensate for that and really make sure that I'm angling the blade down. And you can see now that you've seen me operating with the gonio lens. If you make these incisions too far onto the cornea, like this one, if you make them too anterior, like you would perhaps for a phaco, you then can't manipulate with the lens on because the lens is hitting the instrument. So that's why we have to go so peripheral. But of course, the risk of going peripheral is you're more likely to get iris prolapse, and it also is more of a fulcrum when you've got your instruments in the eye. So it's a fine balance of all of those things. All right, so once again, I'm introducing it, lying it more or less where I want it to be. And now I'm going to get the Grieshaber forceps and the gonio lens. So there you see that lovely bright white line. That is the back of Schlemm's canal. And now I'm introducing the suture into it. You can see how incredibly thin the trabecular meshwork is because it just sort of gives way. And I try and maintain the curve as we're going. And you see how you can see that lovely stripe of blue. So we know that that's in Schlemm's canal. It's a little difficult to see up there, but it's looking very convincing. When you're doing the procedure, you notice that the iris is moving a lot, which it did start to do there, or that the pupil is being displaced. You've just got to think about the possibility that maybe you're in the wrong place. So I'm just watching that. But as you say, it's not presenting where we'd expect. So we're just a little concerned. Okay, so I'm going to pull it out. But you can see how we've actually done pretty much at least a 180 goniotomy. So it's cutting all around there as I'm pulling it. And even though we didn't have the satisfaction of seeing the catheter make the full 360, we know we definitely treated at least 180 of the angle, which in adult glaucoma is actually plenty.